Fluorescein is transmitted to the eye via the retinal and choroidal vessels. If there's anything blocking or reducing the regular blood flow, the affected vessels will not have the usual fluorescence. Vessels can either show absolutely no fluorescence, hypofluorescence, or irregular fluorescence. If the closure is complete, the hypofluorescence will last throughout the entire angiogram. If the closure is partial, there will be a delay or partial filling of that particular vessel. The central retinal artery is the main branch of the ophthalmic artery. The short posterior ciliary vessels, which feed the choroid, are also branches of the ophthalmic artery. The cilia retinal artery is a branch from the choroidal circulation and the short posterior ciliary arteries. We will begin our discussion of artery blockages by looking at the central retinal artery. This 66-year-old male had a one-day history of blurred vision in the left eye. His past medical history is positive for having had an angioplasty about 10 years ago, cardiac stents about 8 years ago, and a history of controlled hypertension. The vision in the right eye is 20/20 and the left eye is light perception only. You can see on the color photograph there is intense retinal edema and the typical cherry red spot at the site of the fovea. The reason the fovea is not white is there is no nerve fiber layer to get swollen and white. The retina is also thinner there, and you can see the RPE and choroid easier through this thinned area, and that is what gives the cherry red spot. Here is an early phase of the angiogram of this patient. Because this is a central retinal artery occlusion and not an ophthalmic artery occlusion, you can see a good choroidal flush. The vessels on the disc are filled because they are also getting filled from the choroidal circulation, but the rest of the retinal circulation is not filled and is therefore still hypofluorescent. About a minute into the angiogram, there's partial filling of the arteries, and the white arrows point to where the arteries have not yet filled. The veins still have no dye at all because the peripheral capillary system is not filled yet. At the 3-minute mark, the arteries are filled. There is irregular caliper of the macular arteries, which is a sign of very slow flow. The temporal peripheral veins are not yet filled. The nasal veins have filled, however, because there's a shorter distance from the nerve to the capillary bed and to the venous system. This patient lost vision 2 weeks prior to presentation and has only a small paracentral island of residual vision. She has a history of heart surgery, angioplasty, diabetes, and hypertension. She has a central retinal artery occlusion with an intact cilioretinal artery. You can see the intense whitening of the retina and a cherry red spot. There's a normal reddish look to the macula nasally because her intact cilioretinal artery is supplying the retina in this area. This photograph was taken at the 34-second mark. At this time, the retinal arteries and veins should be filled. Here, there is a normal patchy filling of the choroid. You can see the intact cilioretinal artery and its capillary bed, but the central retinal artery, and therefore the veins, still have not filled. There are a number of things to notice at the 3-minute mark of this angiogram. The most obvious is that the veins are still hypofluorescent as the venous side of the circulation has not yet filled. Notice also that the superior nasal artery is still not filled. The intact capillary bed of the cilioretinal artery circulation can still be seen. But also notice the moth-eaten look to the filling of some of the retinal arteries. The 3 arrows point to 3 such arteries. This moth-eaten appearance can occur when there is extremely slow flow. You will come across this again in the artery occlusion section of the atlas. This is a case of just the opposite phenomenon. This patient has a ciliary retinal artery occlusion. You can see the artery coming off the temporal edge of the nerve, and the papillomacular bundle is intensely white from the edema from the occlusion. The rest of the vasculature is normal. There are three different findings on this angiogram to notice. First is the non-filling of the proximal section of the ciliary retinal artery. Second is the hypofluorescence in the papillomacular bundle, secondary to non-filling of the capillaries and the blockage from the edema. The white arrow points to backfilling of the cilioretinal artery. The intact capillaries adjacent to the occlusion are filled by the normal retinal circulation, and they backfill the non-perfused peripheral portion of the cilioretinal artery. This is a phenomenon known as either backfilling or retrograde filling. This is a branch artery occlusion, and that can be seen quite easily in the inferior macula. The occlusion is old, and that is why there's no residual edema. All you can see is the sclerotic arteriole. Some patients who have had an old branch artery occlusion may not have the same changes as easily seen as this clinical example. However, the angiogram can point to the correct diagnosis. Here's a late angiogram of this last patient. Note that while the artery is filled, it is not as fluorescent as the superior arteries. Also, one key to the diagnosis is the delayed filling of the inferior vein. So even though the artery is filled, it is slow, it does not have good flow, but also the poor filling of the vein also points to this particular diagnosis. Now we'll proceed to retinal vein occlusions. They can be divided into ischemic or non-ischemic, or by the number and location of veins occluded. Because we are concentrating on angiographic findings, this section we will be looking mostly at ischemia versus non-ischemia. For a full discussion on macular, branch, or central retinal vein occlusions with clinical findings, prognosis, and treatments, I'll refer you to those folders on vein occlusions in other areas of the atlas. This is a 65-year-old male who has had 2 weeks of blurred vision in the left eye, and vision is recorded at 20/70. Notice the moderately severe hemorrhages in all 4 quadrants. The veins are also quite dilated. Because cotton wool spots are caused by arterial occlusion, there are none in this case. The angiogram here should be read from the top left to the top right and then bottom left. The bottom right is a composite. The top left is the early phase and it shows filling of the arteries. The veins are dilated and tortuous. You can also see some laminar flow in the major retinal veins. The hemorrhage is blocked eye as you would expect. The midphase in the top right photograph shows normal filling of the capillary bed, thus making this a non-ischemic central retinal vein occlusion. The bottom left photograph is the late phase, and it shows leakage in the macula, signifying that this patient's visual loss is most likely secondary to macular edema. This is a 57-year-old male with blurred vision in the left eye of recent onset. His vision is recorded as 20/25. This is another example of a central retinal vein occlusion. While the hemorrhages in this patient are not as prominent as the last example, they are in all 4 quadrants, thus making this a central retinal vein occlusion. The early phase of the angiogram shows normal filling of the arteries. The veins are not yet filled. The midphase of the angiogram on the bottom right shows delayed filling of the veins and they have laminar flow. There's blockage from the hemorrhages as you would expect, and also, as with the last case, the capillary bed is intact. The late phase in this patient shows a good capillary bed. He has mild leakage in the posterior pole, so he has some edema, but it is not significantly affecting his vision. This is a 60-year-old who'd had 4 weeks of blurred vision prior to his examination. The vision was recorded as only 2/200. She has a past medical history of hypertension, but it was controlled on medications. This central retinal vein occlusion is noticeably worse than the prior patients. She also has 4 quadrants of hemorrhages, but notice the deep, blotty hemorrhages. These are one of the clinical signs of ischemia. The veins are dilated and tortuous. There's a milky quality around the fovea, so there is probably some retinal swelling there as well. This is her angiogram. At the 26-second mark, it shows filling of the central retinal artery, but the veins have not yet filled. At the 40-second mark, the veins are filled, but her capillary bed is gone. You can now see why there is a creamy color look to the retina near the fovea. It is quite edematous from the ischemia. You can see the difference of hypofluorescence of capillary loss in the macula and contrast that to the hypofluorescence from the hemorrhage blocking the dye below the inferior veins. So this is an example of an ischemic central retinal vein occlusion. This ischemia has led to the production of VEGF, and she actually had early NVI at this time. This is another example of an ischemic central retinal vein occlusion. This patient has had blurred vision in the right eye for several months, and it was recorded as only 1/200. The veins are quite dilated and tortuous. There's intense edema in the macula and 4-quadrant hemorrhages. Some of the hemorrhages have the deep blot look, which is one of the clinical signs of ischemia. At the 24-second mark of the angiogram of this patient, the major arteries have filled, and there's diffuse hyperfluorescence from leakage in the macula. But the major veins have not yet been filled. Even though the capillary loss is not as prominent as in the previous patient, you can see the marked hypofluorescence in the periphery, signifying the loss of the capillary network. This patient has an inferior hemicentral retinal vein occlusion. While the hemorrhages are only in the inferior portion of the retina, it is a variant of a central retinal vein occlusion. More on this discussion in the chapter on vein occlusions. This is an example of a patient with a non-ischemic retinal vein occlusion. There are a moderate amount of retinal hemorrhages inferiorly and some intense superficial hemorrhages on the nerve. This is the fluorescein angiogram of this patient, and it shows delayed filling of the inferior vein early on, and a dilated vein in the late phases of the angiogram. The mid-phase does not show any capillary loss either in the macula or peripherally. The endothelium of the veins needs oxygen just as much as any other tissue. Because of this vein occlusion, the oxygen tension in the affected vein is lower than normal. This relative hypoxia leads to breakdown of the tight junctions, and we see this angiographically as leakage from the vein walls, giving the veins a fuzzy look. This is an example of an old ischemic branch vein occlusion, and possibly combined with an old artery occlusion as well. This is a 64-year-old male who had a branch vein occlusion about 2 years ago. His vision is good at 20/20. You can see the sclerotic artery. The white arrow points to the site of the blockage, and the sheathed veins. There are areas of nevascularization along the superior arcade and collaterals in the temporal macula. Here's a more magnified view of this patient. Just a brief word as to why this is not an old artery occlusion. First, you do not develop collaterals as this patient did with artery occlusions. The blue arrow points to these collaterals. Also, you rarely get nevascularization as this patient has with a branch artery occlusion. Notice the difference in the quality of the nevascularization along the superior arcade, pointed out by the white arrows, and compare that to the collaterals that you can see temporally. Red-free photographs are really good in finding and showing the blood vessel and vascular system in the retina. You can see the patches of nevascularization along the supratemporal arcade. You can see areas of blockage and sheathing of the artery, and then you can see the collaterals temporally. The early phase of this angiogram shows non-filling of the peripheral branch of the superior artery and vein. The white arrow points to a closed branch of the superior artery. The yellow arrow points to a closed small arteriole, and the blue arrow points to retrograde filling of that arteriole. Also, compare the fluorescence inferiorly with the relative hypofluorescence of the capillary bed superiorly, and then also the slow filling of the vein superiorly. The late phase of this angiogram shows the leakage from the neovascularization along the supratemporal arteriole, and that obviously is a response to the ischemia of the superior and supratemporal portion of the macula. Note that the collaterals in the temporal macula do not leak. And for your viewing pleasure, here's a magnified look at the difference in the fluorescence between neovascularization and collaterals. The neovascularization leaks, whereas the collaterals do not. Now that we've covered the major artery and vein filling defects, we will now move on to the capillary system. While there are obviously many systemic diseases which can cause capillary closure, as you can see from the graph, the angiographic pattern of all of these have similar characteristics. We will concentrate on the angiographic patterns and show just two examples. Much of the correct diagnosis will come from a thorough history taking to sort out the correct diagnosis. Specific examples of the other diseases will be covered in other chapters. Diabetes is the classic disease giving capillary loss. Usually it's in the posterior pole, but it can also affect the peripheral capillary system as well. A full discussion of the clinical signs of ischemia can be found in the clinical findings folder. However, this patient has a few clinical signs of ischemia which we will go over. Venous beating is one. The white arrows point to several of those areas. IRMA, or intraretinal microvascular abnormality, is another sign. The blue arrow points to an area of IRMA. And deep blot hemorrhages are another sign, and you can see these in the temporal macula. The next slide will be the angiogram of this patient. There are many features of capillary closure on this photograph. The white arrows point to the venous beating, and it can be seen more easily on the angiogram. The black arrows point to many areas of dark hypofluorescence. These are the areas of capillary non-perfusion. Many times at the border of the non-perfused areas, you can see microaneurysms or IRMA. The red arrow points to the deep black area of hypofluorescence, and this corresponds to the hemorrhages which blocks the dye. Here's another example of a diabetic patient. This patient is a little farther along in the disease process than the previous patient because he already has disc nevascularization and a patch of nevascularization just superior to the nerve as well. Inside the blue circle is what we call a featureless retina, meaning it is avascular. The white arrow points to a small vascular loop, and this is also a sign of capillary loss. More on this feature in my clinical signs folder. The blue arrow points to some visible ERMA. You will see more ERMA on the next slide, which is an angiogram of this patient. And as promised, here's the angiogram of that patient. The neovascularization on the nerve is just beginning to leak, and you can see the hyperfluorescence there. The patch of neovascularization about a disc above the nerve also is just beginning to leak in this early phase of the angiogram. This patient has a much larger area of capillary non-perfusion than the previous patient. ERMA just above the fovea can be seen on the angiogram, as well as inferior to the nerve and along the inferior temporal arteriole and the veins. This is easier to see here than you can see on the clinical photograph. Here is a 45-year-old female who reports blurred vision in the right eye for only several weeks. Her vision is 2200. With the hard exudates that you can see, this problem, however, has been going on for a much longer period of time. She just happened to notice it. 6 years ago, she had had radiation for an undifferentiated carcinoma of the right ethmoid sinus, orbit, and middle cranial fossa. She has the typical signs of radiation retinopathy: hemorrhages, vascular attenuation, telangiectatic vessels, microaneurysms, and hard exudates, and some faint cotton wool spots. These obviously are all signs of diabetic retinopathy, but they can also be from other diseases causing capillary closure. While the clinical picture and angiographic pattern are similar to diabetic retinopathy, the pathology of radiation retinopathy is different. In diabetic retinopathy, there's a loss of the pericytes, and subsequent to that, loss of the health of the endothelium and the capillaries. But in radiation retinopathy, there's a loss of the endothelial cells primarily. This angiogram shows that the major vessels are patent. However, there's extensive capillary closure in the macula and some areas more peripherally, and the dilated telangiectatic vessels are easily seen as well. This is a 40-year-old African American male with a diagnosis of lupus. He has had blurred vision for about several weeks. The intense edema of the nerve fiber layer is seen as the very white cotton wool spots. Deeper retinal edema surrounding the macula shows up as a creamier colored lesion. The left eye had a similar clinical presentation. The wide blue arrow points to the hypofluorescence caused by a combination of retinal edema and loss of the capillaries where the intense cotton wool spot is. The narrow blue arrow temporally points to the hypofluorescence secondary to capillary dropout. The white arrow shows where an arteriole is closed, leading to this loss of capillaries in the temporal retina. Diseases and processes which can cause loss of the posterior capillary bed can also cause loss peripherally. However, there are several entities which tend to cause peripheral capillary loss exclusively or in addition to the posterior pole. A few of these processes which can affect the peripheral capillary network are sickle cell disease, familial exudative retinopathy, Coats disease, and retinopathy of prematurity. As you know, most of the neovascularization in diabetics is posterior, and most of that on the nerve head. But that should not stop you from examining the periphery. This diabetic patient not only has posterior pathology, but you'll see how peripheral the pathology can be, and the angiogram can certainly help on this examination. Here is the fluorescein angiogram of the last patient. You can see there's a lot of peripheral capillary dropout. There's a slight amount of hyperfluorescence from leakage from disc neovascularization, but there's also leakage from neovascularization in the mid-periphery. And as usual, This nevascularization can be found at the border of ischemic retina and perfused retina. This is a 41-year-old African American female who is referred to the clinic for some vague eye pain. Her vision was 20/20 in both eyes. She has some subtle vascular changes infranasal to the nerve. They're not so easily seen even on the blow-up in the insert in the upper right of this photograph. The exam of the right eye showed even more subtle vascular changes. The patient returned to the clinic a year later because she developed a vitreous hemorrhage in the left eye. An angiogram was done at that time. Both the nevascularization and the capillary loss are seen better than on the color photograph that was taken a year before. She subsequently received PRP and the vessels have regressed, and she's done well over the ensuing years. The fluorescein angiogram of her fellow eye shows leakage in the far periphery from some nevascularization, and that is secondary to some mild peripheral capillary loss. At this time, she's not yet had any treatment, but she's being followed several times a year. Here is a more obvious example of peripheral vascular changes. This is a 35-year-old African American female who presented with some new floaters in the right eye for about 2 days. She reports intermittent decreased vision over the past year, lasting for several days at a time. She's a mild myope, and her best corrected visual acuity is 20/20 in both eyes. There's some mild vascular tortuosity in the posterior pole, but in the periphery you can see some C-fans with some fibrosis, and those are seen both temporally, superiorly, and infratemporally. There's also a very mild pre-retinal hemorrhage peripherally. And here's this patient's angiogram. Because the peripheral capillary bed is an end bed, there are no more peripheral capillaries past where they are blocked. This gives a very dark hypofluorescent pattern peripherally in the sickle cell patients, which may not be as apparent if the capillary blockage is more in a posterior pole where there can be some collateral circulation. This example is a little more dramatic than the prior one. You can see on the clinical photograph there's some nevascularization, there's some fibrosis, and pre-retinal hemorrhaging. The fluorescein very easily shows the C-fan nets of nevascularization and the very dark peripheries, which is caused by the capillary loss. This brings us to the end of the vascular filling defects chapter. Obviously, it does not cover every disease, but the most common processes and diseases have been covered.